Hello, my name is Ian McCollum. This is an overview of Module 1B of the training course. What are we going to look at in this particular module? Well, we're going to look at the morphology of solar damage, a little bit on BCCs and SCCs. We're going to do a bit on basic skin anatomy. We'll look at a video on derm path terminology, and a little article on the reliability of punch biopsies, and a tutorial on the congenital oral leukoplakias. This has been covered already in the section in resources. If we can go there, and in the tutorials, it's done in much more detail here, but we'll go into small aspects of it in the other section. So if you need more information on any aspect of that, you'll find it in the tutorial section in resources. But let's get back to the module today that we're going to look at. These are the questions that I'd like the doctor assigned to this module to deal with. And think about them when I go through this. How accurate are punch biopsies in non-melanomatous skin cancers? It's an important topic because we use punch biopsies to assess both our margins of excision of lesions, and sometimes when we're using non-surgical treatments, it's determined by the nature of the tumor that we're trying to get rid of. Second question there was, other than UV light, what are the other causes of non-melanomatous skin cancers? I think we tend to get sidetracked and think that UV light's the main cause of virtually all non-melanomatous skin cancers that we see, but that isn't the case. Third question, what's the gene defect for both sporadic BCCs and the multiple BCCs seen in the basal cell nevus syndrome? And why is it important? And the main reason is because of some of the new drugs that have been developed to deal with the gene defect, particularly in people with really severe BCCs and those with the basal cell nevus syndrome. And then the last question there, what do we mean by field defects in skin cancer? Field defects. You know, you've got tumors occurring over large surface areas, or sun damage at least. And what influence does this have, this concept of field defects have, on the treatments that we choose when we're dealing with these lesions? Have a think about this in relation to some of the treatments such as PDT, imiquimod, Effudex, and when we choose these and why we should perhaps choose those therapies and what the problems are in choosing them. These will be the issues that the module, the doctor assigned to this module, will look at. Now, there's a lot of material here. I'd hope you have time to look through some of this, or at least look at the video that's in fact here. This will cover some of the material that was in the initial chapters that I did for the Diploma of Skin Cancer Medicine and Surgery for the Skin Cancer College Australasia. Some of it will be basic, some of it will be quite useful to first year. Fourth year, third and fourth year will know all of this, but you can just skim over it. Look at the morphology of solar damage. It's important as dermatologists that we can look at the skin and should be able to assess confidently straight away whether something's a solar keratosis, whether it's an invasive SCC, whether it's a superficial BCC or an SCC in situ. I mean, I can tell you that even after a lifetime of, or seems to be a lifetime of doing dermatology, I can still have problems with some superficial BCCs and SCCs in situ. We usually think of superficial SCCs as having a lot more scale than BCCs, and that's in fact true, but I've seen a lot of scaly superficial BCCs in my time. But concentrate on the descriptions given in here for the morphology of these basic things. We've mentioned here about the importance of total lifetime sun exposure. That's the whole thing about ultraviolet. It's cumulative. The damage is cumulative over the years. There's DNA damage, and with that DNA damage, the body has the ability to repair it. There are DNA repair mechanisms. Have a look at xeroderma pigmentosum, an inherited disorder with a series of subtypes with various gene repair defects and the problems that they get. Rare condition, but an important one to pick up early. And the hint would be if you see a child that's got an excessive amount of freckling at an early age and even some signs of solar keratosis, then consider them as potentially suffering from xeroderma pigmentosum. Basal cell skin cancers, you've got to be able to recognize the various types. The superficial, always look at the edge, that pearly infiltrated edge that you're liable to see in superficial BCCs. The nodular, the cystic BCC, the use of a dermatoscope. You think of them mainly in terms of pigmented lesions, but they're very, very useful for non-pigmented skin cancers as well, especially the early and small BCC. You can pick these up on areas like the nose and eyelid skin with a dermatoscope so much better than just with the clinical eye. And the thing is, when they're so well defined, these things can be taken out with 2mm margins without any problems at all. And it means often, if you pick them up very early, that it's just a simple ellipse excision on the nose and other structures rather than a big flap repair. Make sure you can recognize a morphic or an infiltrating basal cell skin cancer. Clinically, you can just sometimes have white areas on the surface of the skin. And it's not called morphiiform for nothing. It does look like a plaque of morphia. They are wicked lesions to try and diagnose, and you don't want to miss them. The recurrent basal cell skin cancer, very important. Whenever you've got a recurrent tumor, it always extends much further than you think. It's not just a case of doing a little excision at the side of the scar. You'll usually find it extends under the scar as well. And this is one of the areas where Mohs surgery is very useful in delineating where these lesions really extend to. The problem, recurrent BCCs usually come about because you've taken the BCC out with inadequate margins. And there are certain types of BCCs that are more aggressive, such as the micronodular BCC, obviously any infiltrating or morphic BCC. They've all got to be regarded as being likely to recur, and so you have to take them out with appropriate margins, and that can mean at least 4mm for some of the micronodulars, and for the infiltrating BCCs, anything between 5 and 7mm might be necessary, and this is why Mohs is so useful. It minimizes the amount of healthy tissue that needs to be removed. These images we in fact discuss in this video up here. It goes through all the various images and more that aren't here. The basal cell nevus syndrome, you should know a little bit about that. Why? Because there are these new drugs that are available for the gene defects that occur in this syndrome. This video here goes over some of these new drugs and some of the clinical results of their early use. These drugs have been available in the United States, and there'll be new ones coming out. There's various drug companies involved with them, so you need to know a bit about them. So if you've got time, have a quick listen to this video. These are just some pictures of the basal cell nevus syndrome, some of the clinical features that you'll in fact see. Watch for the Palmer pits. Have a look at the other conditions that can cause Palmer pits as well. Solar keratoses, I think histologically they form fruits of SCCs. They're just SCCs in an earlier stage of development. The damage is in the lower 2/3 of the epidermis. That's where the atypia of the keratinocytes is found. It's not in the upper part. Don't think that it's the upper layer. The upper layer, in fact, looks normal. And you can see the problems that pathologists sometimes have in deciding whether something is a solar keratosis or is an SCC in situ. It's often just a degree. It depends how it's been sampled often as to whether something will be reported as an SCC or an SCC in situ or a solar keratosis. You'll sometimes see the term bonoid solar keratosis used. I hate that term. I mean, if it's boenoid, it's almost Bowen's disease, virtually full thickness. Call it Bowen's disease. Call it SCC in situ. We don't call it boenoid solar keratosis. Take that point up with your pathologist, see what they say. There are all these other lesions that you need to know a little bit about. Seborrheic keratoses, there's multiple variations in those morphologically. Porokeratosis, the disseminated superficial actinic porokeratosis, inherited in autosomal dominant, takes about 20 years of sun exposure before it all comes out. Once you get your eye in those, you'll pick them up, but look at some of the pictures that are in the video there. Flegel's disease, hyperkeratosis lenticularis perstans. Rare disorder. We had a case of this recently that came up in the derma. One of the dermatologists put a case up, and I must admit I didn't quite recognize it. One of my colleagues did. So maybe have a little look up about that. SCCs, you need to know the various types. SCCs, some pathologists will actually give you a depth of invasion of an SCC. Give you an idea of the thickness of it. Most will tell you whether it's the degree of differentiation, whether it's well differentiated, moderately differentiated, or poorly differentiated. The big thing to watch is a poorly differentiated SCC. Make sure you've got at least 4 to 5 millimeter margins on it, and make sure that there isn't any perineural spread, because if you've got a combination of a poorly differentiated SCC with perineural spread, you are going to have trouble. And always remember to feel the glands, feel the draining glands in an area where you've excised a poorly differentiated SCC. You actually should have felt them before you did the excision, but if the path comes back, make sure when you take the stitches out, you're examining the glands of that patient as well. KAs you've got to know about, you're going to see a lot of them. With SCCs, you've got to know the metastatic potential of SCCs in different areas. I mean, the lips, the ears, the scalp of bald men, these are all bad areas for metastasis. And the other one is the SCC arising in a chronic leg ulcer or a chronic ulcer from some other cause. We call that a marginal ulcer, and the metastatic potential of those is somewhere between 30 and 50%. So, you've got an SCC developing a chronic venous ulcer in the leg. For God's sake, feel the glands in the groin. Make sure there hasn't been any metastatic spread there. The difference between SCCs, or solar keratosis and SCCs, clinically, is that the SCC is more indurated, and it's often more painful to touch. So wherever you've got a painful, indurated thing that you think's a solar keratosis, it probably isn't. It's probably an SCC. So biopsy it before you excise it, or do a primary excision biopsy. Know a little bit about leukoplakia. We're going to talk about white lesions in the mouth later on, I think, as the tutorial topic. But remember, not all leukoplakia is in fact premalignant. Some of it's hyperplasia, and there's just an absorption of water by the keratin there, and it gives the white color. We sometimes have SCCs on the penis as well. Remember that SCCs there can be induced by oncogenic viruses. Remember that initial question for the doctor doing this module on the other causes of non-melanomas or skin cancers. There's some other tumors we put in there, Paget's and extramammary Paget's. You should know a little bit about this. We'll be covering this later in a variety of ways, because they mimic dermatitic conditions, either on the areola of the breast or in the vulval or pubic areas. And we'll come across them later, but know a little bit about mammary Paget's. So when we then go on to the derm path topic, we are going to look at a few things. This initial one, I think, looks at just the initial histology of some BCCs and solar keratoses and what have you. A lot of it's taken from the website that I've done called Dermatopathology Made Simple. And these are some of the images that come out of it. Initially, this video just looks at normal skin anatomy. It doesn't do it in a great deal of detail, but you've just got to get your eye in as to the cells that you see histologically, the arrangement of melanocytes to the normal stem cells that you see along the basal layer, the importance of the stratum granulosum, and a little bit about the anatomy of the dermis with your retiridges and your dermal pegs, the blood supply to these in the skin, and the adnexal structures. And this video that's there goes into this particular topic. But just get your eye in and looking at these. You'll be looking at a lot of slides before you're finished. There's actually a link to a virtual microscope. Now, a virtual microscope allows you to go in and look at these particular images as if you were looking at them. You can look at them on your computer screen as if you were looking at them on a slide, a microscope slide in front of you. So they can be quite useful. There's also a video here on descriptive terms in dermatopathology. Now, again, if you're a little bit further on in your course, it would be useful to have a look at this. It goes into, terms like acanthosis, acantholysis, hyperplasia. It looks at the different types of keratin that you'll get, ortho and parakeratosis, and the importance of that. And it looks at, leukocytoclasis, eosinophilic infiltration, eosinophilic spongiosis with eosinophilic abscesses in the epidermis, describes those terms. Doesn't go into them in a great deal of detail, but again, it's just to get your eye in and get you used to vocabulary. Vocabulary is so important in all aspects of medicine, but certainly it's important in dermatopathology that you know what particular terms mean. So have a try at a chance of listening to that and looking at that particular video. This was a little paper here on punch biopsies, and it's in relation to that question that I asked the doctor who's doing this to go over. So the doctor who's doing this module will look at this and will present some of this in a PowerPoint form. The Dermatology Online Journal. Initially I was going to look at important articles from the JAD and from the archives, and I still will probably put some of those in now and again, but I like this Dermatology Online Journal, and the reason I like it is that there's going to be something in it for all of you from first year right through, and it often has some interesting cases, and it often has some interesting images that are there. So I'll probably have a quick flick. For instance, if I was looking at this particular issue, I'd have a quick flick in here. And I think this goes back to the January 2011 issue. And you can see, acne in adolescents, an important topic, quality of life issues. There was a thing here about complete regression of melanomas associated with vitiligo. I'll have a wee look at that during the webinar as well. I think what were the other things that I was going to look at? That one there, an extensively pigmented vulvar, BCC, presenting as pruritus in an elderly woman. Vulval rashes and vulval tumors are very important, so we'll probably have a little look at that as well. Some of these I haven't fully looked at yet. If I think they're interesting, I'll bring them up when we do the webinar itself. That was someone had written in on acral lentiginous melanoma. We might have a wee look at that and see what the comment was. Anyway, as I say, I like this journal, and I'll bring some relevant things up from it. The tutorial topic that we'll look at in the webinar, well, the congenital oral leukoplakias. These are the various conditions here: white sponge nevus, pachyonychia congenita, dyskeratosis congenita, hereditary benign intraepithelial dyskeratosis, and Diarrhea's disease. Again, this will be of more relevance to third and fourth year registrars if they want to get a little bit more information on causes of white lesions in the inside of the mouth that are present at birth or shortly afterwards. Mind you, a lot of cases might well just be a bit of candida as well. You've got to remember that. And if we have some good clinical cases, I'll have a quick flick to those, any that I might have had in my rooms that I think are important, or any that perhaps have come up in Global Skin Atlas. We'll flick into those. So I'm not going to go through in the webinar itself all this material. You can have a look at it beforehand if you wish, and it'll depend on obviously all the other things that you have to do as a registrar, as the amount of time you have to look at each of these things. You can obviously come back to them again later on. Most of the discussion will be between myself and the doctor who's assigned to this module, but if you've got some questions and issues you want to bring up, raise your hand during the webinar and we can chat about them. Thanks very much.